Welcome to the first Talk with the Doc of 2026. And as always, we have Dr. Timothy Leichliter, Movement Disorder Specialist Neurologist from Allegheny Health Network. He's here to answer your Parkinson's related questions. Thank you, Dr. Leichliter. Thank you, everyone, for joining, and please take it away.
Thank you, Kate. Happy 2026. It's hard to another year. I've been telling everybody I'm optimistic for 2026, although January definitely didn't leave me so, but February is looking good. Maybe. Well, welcome everybody back to the party. For those of you who have been here before, well, you know the deal. For those of you who haven't, welcome to the party. I'm Dr. Lickletter, sitting in my office here at Allegheny General Hospital, looking out my window at a very cold hillside. Um, this is a good place to ask questions. I have a whole bunch of questions in my emails that I'm going to start with, but eventually I'll get to ones in the chat session. If again we run out of time or there's too many, then I can always carry some over till next time. But your best bet on here is type them in the chat box. My caveats that I always give you is this is a good place to get general information. This is not a very good place to get you specific treatment strategy options. That's a good conversation for you and your doctor, but feel free to ask away. I'll do the best I can. Um, and at the end of the day, the last thing I like to tell you is everything you get is my opinion. I have a lot of opinions. I will share my opinions freely. I like to think my opinions are based in as much science as I can muster, but sometimes I have to make stuff up and I'll let you know. Um, and if you go down the street or you go to a different neurologist or a different provider, they may have a different opinion. It's okay. We're all allowed to have opinions. So without further ado, I am drinking Earl Grey. I like Earl Grey. Don't really know what bergamot is, but it's delicious. Um, let's get to some of these questions. So the first one was actually from, I think the first couple were actually from last time. So one was about the beach band. The beach band is a band that you can wear that gives vibrations to it. It was invented, it looked like by a young onset Parkinson's disease patient. It seemed to me when I was reading through it, and I won't go through all the details, that it seems to be more of a calming thing, an anxiety thing than a true physical symptom thing. But again, I'm not against that either because as you know, if you do have Parkinson's symptoms and you're upset or anxious or nervous or agitated or not calm, everything does get worse. And so I think that's what he was noticing the majority of the benefits. But then he goes on to notice that this vibrating kind of wristwatch thing does help with a lot of his symptoms, his walking, things like that. I've had two patients, I think, recently order them. I have not had anybody come back and said, "Hey, I got it, I tried it, and this was my end result." So I'll hold off on telling you what I think of it because I don't have any experience yet. But I did read up on it, and it does seem at least somewhat interesting and fairly low risk. The other thing that I was told to read up on was Right Brain Bio, and I was reading up on this as well, where the thought is kind of the opposite or counterintuitive to traditional Parkinson's disease thinking, which is loss of dopamine, is what leads to the symptoms, and dopamine replacement is the end result. But they were actually postulating or coming forth with this idea that perhaps you have too much dopamine, at least too much kind of immeasurable dopamine, and that's toxic to the brain, and we really need to rethink our strategy. Um, Again, I don't know. I haven't done any of these research studies myself. Um, I can only read what is written and postulated, and so I go with the literature and see what everybody says. I'm interested in any novel ideas, and that's not the first time I've read that idea. There was a pretty prominent or outspoken movement disorder specialist in Cincinnati, I think, Dr. Espay, who's very high up in the movement disorder world, who also had this a talk on this stuff. And so there could be something there, but at the end of the day, I don't have anything that I can do about it. I'm interested in more research, more publication showing me, A, what they think the toxicity is, but B, what can we do about that? Again, as far as I know for now, the medicines that we have that are really all aimed at trying to increase, hold on, Donna, that are all aimed at trying to increase dopamine are still the best medicines that we have. They're the most proven. But I'm always willing to see, okay, what's coming up next. We know that the medicines that I'm giving people are not fixing anything. That's not a fact that I try to hide. I lead with that usually when I'm giving people medications. And so if I'm only treating symptoms and that's helping, great. But if there is a way to get to the underlying problem and correct that and work on that, I am more than, willing and all ears to try to hear it. All right, Donna, what do you got?
In line with what that hypothesis that we assumed was the lack of dopamine, and he's saying that it might be wrong. Dr. Espy, Albert Espy, just gave a talk on Monday
Hmm.
concerning another hypothesis that we're all assuming is correct from that Brax study, that 30 13,000 references. But anyway, he's saying that the clumped alpha-synuclein is not a cause of Parkinson's. It's maybe, and it's not even a marker, but he's looking at this other, it's the second really bad, I mean, really concerning thing that we may be using the wrong hypotheses. So one's concerning dopamine, and now it's concerning alpha-synuclein, which all that marker study is based on. So that, and they had researchers on this talk that were arguing back and forth. I don't know if this is going to be addressed at the World Conference, but I mean, this is really
Welcome to
concerning
my
to me.
world.
Yeah.
Welcome to my world. There is not a lot of agreement, and neither of those are actually new conversations. So we've been talking about alpha-synuclein for 30 plus years. And it's been studied. And just like tau and Alzheimer's disease, again, there's been a lot of back and forth on these things. So just to expand a little bit for everybody else. So alpha-synuclein is the misfolded protein that clumps together, and we can see on pathological stains as Lewy bodies. Lewy bodies are the pathological hallmark in autopsies of not only Lewy body disease, but also people with Parkinson's disease. And since, if you go back 200 years and we don't have a lot of good studies or good ways to study things, our best mode of action was autopsy and staining and looking at sliced brain tissue and seeing what we found. And lo and behold, if you slice open people with Parkinson's disease brains and you stain it correctly, you get these pink and purple clumps that are Lewy bodies that, after much further exploration, was found to be alpha-synuclein. There has been tons of talk about whether or not that is the cause or is that a byproduct. And that's an incidental finding. That's what happens after whatever it is that triggers Parkinson's disease finally destroys the cell. Maybe that's the end result. That's the end result of your nervous system battling whatever it is that is causing the problem. And they have been arguing this back and forth for years. And this is exactly what happens in my conferences. You get two researchers or two people who have different idea, and they do this on purpose in my world, and they put them together and they make them argue about this stuff. And it makes it interesting, but I don't know that we were actually have gotten closer to trying to solve that problem. The same thing is true with dopamine. The reason why we think dopamine is a problem is back in the 1950s or 40s, we would stain the substantia nigra of people with Parkinson's disease. It does not stain black like it's supposed to, and that's where we found the dopamine producing cells were. And so that's what led to the dopamine hypothesis. Um, Again, that was 80 years ago. Even though our technology has improved and even though our ability to do research has improved, we still have not actually answered these questions. This is why when people come to my office, one of the first things I say is, I don't really have definitive tests for these things. We have not solved all the reasons why people get these things. We don't know why people have these problems, nor can I fix any of these problems or slow them down. These are a lot of the conversations that I have early on, not only because I want to make sure I manage expectations and set expectations outright, whereas, and this is not a hit at any of my patients or people specifically. I think this is just a general understanding is people do watch a lot of doctor shows or a lot of TVs, and they go to the hospital or they go to the doctor and they say he's going to come up with the answer and he's going to come up with how you fix it. And then they get to my office and I say I can't do either of those things. And then they sort of get mad at me, but as I explain it to them, they kind of come to an understanding why in my world there are not a lot of definitive answers and there are absolutely no fixes. And so this is really one of the biggest problems that we have. And so, and Alberto, he's a great speaker and he is a very intelligent guy and has done a tremendous amount of research, but he often does bring up these different or kind of conflicting ideas to what the norm is. And it's always good to have him on boards and on committees and on panels because he's always the one to get the party started when it comes to the argument. And I love listening to him talk. I didn't hear his most recent one, but I have heard him talk about all of those things in prior conferences. And so the short answer is again coming back to these hypotheses, we still don't know. We still need more research, more definitive research, more answers, and we still need good solutions. And I don't think we have good either of those at the moment. Again, as I hear more, as you come up with more or listen to more, definitely bring them up and we'll talk about them. Because I do think it's interesting. I don't think it helps us out here at the moment because I haven't had any new breakthroughs in like treatment strategies based on this information or not. I think this is just step one in terms of multiple steps that are going to lead to those kind of things. But I think there's something we all have to pay attention to.
I put
The
in the
other,
chat
good.
the YouTube video if anybody else wants to listen to it. And this is from Ben Strecker, who did
Mhm.
the AI review of this because he wrote that book, Brain Fables,
Right.
with Albert Espy. So he summarized it using AI and in a simple way, but you can actually, that's the link to the actual YouTube video of the talk. But
Try to put it in again because all I see is very interesting talk that I would like your opinion on, but I don't see a link.
oh,
So maybe try putting
the
that in again.
it's in the middle of that paragraph. H on you, it's underlined in blue on my screen, or at the end on the YouTube video.
If it is on everybody else's, that's fine. It's just not on mine. But
I'll try to do it again, just
okay.
the link then. Okay.
The other talk that I had from, I think, over a month ago, or a question that I had was about vaccines. And I thought this was an interesting question. And the question was not only just on vaccines in general and their impact on people with Parkinson's disease, but specifically, is there any difference between live or the inactivated vaccines? Because again, if you go to doctors, I'm sure they all recommend all these vaccines. And believe me, I am not the vaccine expert in terms of who is supposed to get what. This is what I rely heavily on on primary care doctors for. I did do a little bit of reading because I was a little bit unsure. And I say that because generally I recommend to my patients, yes, whatever vaccinations your primary care doctor thinks you need, you should get, because generally getting those diseases is worse than whatever the vaccine's going to be. But I've also had plenty of patients come back, particularly after the COVID vaccine, but even with flu shots or other things like that, where they do tell me that their symptoms got worse. Enough so that it did make me think and made me go look it up and do a little bit of a review. And the review that I came up to said exactly that, which is there are plenty of reports of patients noticing that their symptoms do get worse following vaccines of any kind. Although their suggestion was that most times or more often not, it's a temporary worsening. Although I have had patients come back and say, no, I got worse. But generally, the at least what I could find in the literature and in my quick review was there's no good reason to exclude Parkinson's disease patients from either live or inactivated vaccines. There wasn't any difference between the different types. And so my general recommendation to patients is yes, you should get them. Again, whatever your primary care, whatever the powers that be are recommending at the given time. Just know that there could be a temporary worsening of your tremors or stiffness or slowness of movement, and that I have had patients, not many, but some patients, where maybe they did notice a worsening of their disease in general. Again, my general line of thinking is that it's still worse to get that whatever disease is, as opposed to the worsening of your symptoms from the vaccine. And that was sort of the literature review that I could find. That's what they recommended as well. And so that's what I'm going to continually tell my patients. I have plenty of patients that say, no, I had a bad reaction to that vaccine. I'm never getting it again. And believe me, I'm not here to push you to go get vaccines. If you had a bad reaction or there's an issue or there's a reason why you shouldn't get a vaccine, okay, I'm all for that. But for the majority of patients or for your general person coming to my office, I usually say, yes, you should get whatever vaccines they say. And I think the risk is pretty low. Can I share my thoughts on high intensity focused ultrasound for Parkinson's? Yes, I can. So when it comes to tremors or Parkinson's disease, there are a couple of more invasive or aggressive technologies that we use or utilize to try to help symptom management. The two that usually we go to are deep brain stimulation and now high frequency ultrasound ablation or an ablation. An ablation just means a hole. So we learned a long time ago that if you put a hole in somebody's brain, you can more or less control their tremor, at least for a time. I believe, and I only say this because he mentioned it in his book, he is not my patient. Michael J. Fox had an ablation. Now, he had the old-fashioned ablation, which was you would have a hole drilled into your skull, a probe put into your brain, and they would burn or they would freeze a hole, and then they would take it out. Fast forward to about, probably coming up on about 10 years ago now, they did some research and they found that they could aim ultrasound waves under the guidance of an MRI, and they could heat up tissue in a very precise manner and burn a hole in your brain without having to drill holes into your skull. I have not had a tremendous amount of experience with it yet for Parkinson's disease. And the main reason for that is I don't have it here at Allegheny. We have been doing deep brain stimulator surgery for 20 plus years, but we do not have the technology to do high frequency ultrasound ablations. We did historically do stereotactic radiosurgery ablations. They were not as clean as I would like. They take a few months to mature. It takes a while for you to notice the effect. I don't think too many people in this country, in Europe, they still do a lot of radiation, but I don't think in this country we do a lot of radiosurgery ablations anymore. And now with the invent of high frequency ultrasound, I think you're going to even see less of that. But one of the reasons why I don't have a lot of experience is I don't have access to it directly in my facility. I have sent patients down to WVU. I've sent patients up to Cleveland Clinic. As far as I know, UPMC has one and they've done a few. I don't know how many they're doing outright, but I don't have easy access to it. And that has limited my experience with it. So if you go to one of those places, they will have much more experience than I do, just FYI. The other concern that I have specifically for that in Parkinson's disease is not just a tremor. And while I think that it is a very reasonable thing to help control tremor, I do question how well it helps the other symptoms. And, since we've been doing deep brain stimulation here for a while, I know what it does, at least relatively. And I do feel like it has more of an impact on not just tremor, but stiffness and slowness of movement as well. It's not without its own price or side effects, don't get me wrong. But when it comes to Parkinson's disease, because while the tremor is part of it, I think the other symptoms are as big or bigger of an effect or part of it. That's where I think if you had a technology or you're going to do a more aggressive thing, I would go for one that does a little bit more of both or multiple. Not to say that I won't use the high frequency ultrasound. Only you have to be a relatively good surgical candidate to get deep brain stimulator surgery. And so if you're not a good surgical candidate or there's other confounding variables that make that not as good of an idea, I am all for the other technologies, even if they aren't necessarily going to impact or help with everything. I just haven't done that very much. I have not had that experience. I have used high frequency ultrasound for more essential tremor patients because they predominantly have a tremor. And I've had relatively good success with some caveats. Obviously, nothing's perfect. And so I'm not against doing the high frequency ultrasound ablation for people with Parkinson's disease. I just don't have as much experience with it yet. And so, again, I think as we see how the technologies evolve, as they pick different targets, as perhaps we can start noticing symptom management in other aspects besides just tremors, then I think we might have a different conversation. But at the same time, DBS is also improving or changing. And so I think you're going to see some competition there pretty much for the foreseeable future. Again, these are definitely things that we use when we're not having as much success as we would like with medications. Either we're having to ramp up medicines or the medicines are becoming unreliable or less predictable, or you're just having side effects. Then we do have to think about these other technologies. And that's what I'm always trying to compare and contrast the two based on patient. And all of this is very individualized depending on the patient. The next question I had was regarding two phase 3 trials. One was on Ambroxol. So Ambroxol is, I believe, a cough medicine available over in Europe. Interestingly enough, it does target alpha-synuclein. And coming back to the conversation we just had, whether or not alpha-synuclein is important in the targeting or progression of Parkinson's disease is still up in the air. But that's where it kind of lended itself to use in patients with Parkinson's disease. The data had been looking fairly good in early trials. But again, as you know, if you listen to me talk, I'm going to give you the same answer every time. I really need to see the data. I've seen far too many phase 1 and phase 2 trials where they're doing small groups and small numbers and they're looking at safety profiles that have some effect, and everybody gets excited only to find a phase 3 trial didn't work. And so again, I'm interested. We got to keep an eye on anything because I'm always eager for any other option that I have that are going to help patients do better. That really is my main job in the office. That is my main goal. We have researchers who are trying to solve the problems. My main goal and main job is quality of life of the patients who come to me. And so anything that I can get who might impact that quality of life in a good way, I am all for. and I'm always interested in more things that could potentially be beneficial. The same thing is true for this vitamin B3, which is niacin or nicotinamide um, study that I was looking at. Again, there's been a lot of look at the B vitamins, B12, B1, B6, B3, and they're all being researched or being looked at in trials. Generally, they're fairly safe. They all have some scientific rationale behind them in terms of helping nerve function, mitochondria sparing, so on and so forth. But I'm always looking for more data. It's hard to get data on vitamins, that's for sure, because the trials are expensive. Data is expensive to obtain. And so it's always difficult to get good trials on these things. But I'm always keeping an eye out for these kind of trials so that, if they do work, I am all for using them, but I need to see the data first. Besides proteins interfering with medication, how does nutrition affect Parkinson's disease symptoms? What helps? Do inflammatory foods really make it worse? Um, I hmm, I think so. So this is my opinion. This is probably more my opinion than fact. There was a whole journal that came out probably about 3 or 4 years ago in my world that was all about diet and nutrition. And the general theme was the Mediterranean diet is the best. Now, that's not too surprising. The Mediterranean diet is probably the best diet for everybody on the planet, whether you have a disease or not. And so that's probably what I would recommend. But I really do think diet plays a role. I've had enough people say that, when they start eating healthier, and again, there's a lot of confounding variables because when people start eating healthier, they also exercise more, they also do other healthy things. And so it's always going to be really hard to tease out how much of an impact specifically one of these things has versus another. But I generally do think that people who eat healthier do better. Can I necessarily say for sure that, an inflammatory diet or eating fast food or junk food or processed food directly impacts your tremors and nah, I don't think so, but I do have a feeling it does. I can't prove that. You just have to take my word for it. But again, more and more we're learning about diet. We're learning about inflammatory things. I mean, there's a lot of talk about red dyes, pesticides, all kinds of chemicals, which there's other conversations about. I mean, you have to think that the cleaner you can eat, the better you're going to do. Again, I don't have any good hard data to back that up. That's just my own opinion. But again, I think it's based on what I've not only seen in clinic, but what I also think makes sense. And then I think the last one on this one was this study about coming out of Japan where they're working on stem cells. So lab-grown brain cells reverse Parkinson's symptoms in pioneering trial. So I get asked about stem cells all day, every day, right? Stem cells are not a new idea. Every single one of us who takes care of neurodegenerative conditions has had this exact same idea. I don't think it's a stretch to think that if you look at patients' brains and they're shrinking, or you're losing cells, or cells are dying, and that's causing or at least part of the problem, that regrowing those cells, resprouting those cells, reconnecting those cells would be good. I don't think that's going out on a limb. We've all had that idea, and stem cells have the potential to do that. Now, again, we've been researching stem cells in Parkinson's disease for 20 to 30 years, and we've had successes, we've had failures. Um, I won't even get into the different ways you can collect stem cells and why I give whole talks on this. Just take my word for it. There's a lot of ramifications to certain cell lines and how you collect stem cells, blah, 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 blah. At the end of the day, to me, a stem cell is a cell that I can take and make into any cell that I want, or the cells that I want. In our case, dopamine producing cells. And they were able to do that. And they were able to implant these into patients and they were noticing success, which I think is great. But before everybody jumps on I need stem cells, that's how we're going to cure Parkinson's disease bandwagon. This was, I think, in 7 people in Japan, and I think they did 11 or 12 people here in the United States, if I read it correctly. And these were really early stage phase 1, 2 trials. These were not really trials designed to see if people did better. They were designed to make sure it didn't kill anybody. Make sure they didn't end up with runaway dyskinesias, which happened in prior stem cell trials. Make sure we weren't really causing a lot of harm. These were safety trials. And so while I find it promising, and believe me, every single one of us is interested in stem cells. And I was asked this not all that long ago were what I thought some of the future treatment options in Parkinson's disease were, and stem cells was high on my list because I really do think it lends itself to this type of a condition very well. We just got to get it right. And so while I'm interested in this, I am eager and excited. I don't get excited. As excited as I get for stuff like this, I am also cautiously optimistic because we've been burned far too many times. And so at the end of the day, the next step for what they published, and I forget where they published this study, was they were actually fast tracking state phase 3 trials in the United States, meaning they were bypassing a more in-depth phase 2 trial because the FDA also thought their safety profiles looked really good. And so more to come. I think it's very interesting. I really hope this works because I really do think this could revolutionize or be a big part of future therapies in my world. But I also know to pump the brakes and not get too excited because I've been let down before. Can neuropathy in the feet be related to Parkinson's disease? And does it affect standing balance? Yes and yes. And so it turns out that actually neuropathy and Parkinson's disease go together far more than by chance. So I read a stat somewhere recently that anywhere, and it was a big number. It was somewhere between 30% and like 70% of people with Parkinson's disease have neuropathy, whereas in baseline people, it's like 10%. And so, and I don't know which number's accurate. I don't know where they got those numbers. That's just a that I read somewhere. But at the end of the day, it's definitely more prominent in people with Parkinson's disease than it is in other populations. For a while, it was thought that perhaps carbidopa-levodopa causes neuropathy. So interestingly enough, it's not really thought about or listed in the pill form, but in the intestinal infusion form, it was one of the main side effects. And I've had enough patients come in, kind of like hair loss is not necessarily listed as a side effect under carbidopa-levodopa, but I've had so many patients come in and tell me, I started taking this medicine and my hair started falling out that I can't ignore that. The same thing is true with neuropathy. It could be a side effect of the medicine, but the other thing it could be is there could be a common pathway between the two. So a lot of, and again, coming back to what we were just talking about, a lot of people with Parkinson's disease have B vitamin deficiencies, or their B vitamins aren't as effective as they should be. And that also plays a role in neuropathy or peripheral nerve function. And so at the end of the day, it could be some of the medicine, but it could also be a kind of correlating or coexisting pathology with the same pathway. We don't really know. Hold on, Donna. As far as I know, it hasn't been proven yet exactly what the underlying link is. But at the end of the day, yes, the answer to the neuropathy question is it is correlated with Parkinson's disease. All right, go ahead.
Just funny that you mention this because I have been cutting up Vicky's immediate release Cinemet, the yellow pills, into
Hmm.
halves or quarters with all that dust. And I've developed neuropathy in all my fingertips.
Sure. Does seem awfully coincidental. I can't say for sure though, because I also have a ton of people that take that exact pill that don't come in with neuropathy. And so I'm not sure. Could it be that you were predisposed to it and that triggered it? I mean, I can make up a lot of scenarios. I just don't have a definitive answer. All I can tell you is yes, there is definitely a correlation to that. And that dovetails into the second part of that question, which I think is actually the more important question, which is, does it affect standing balance? And the answer is yes. So outside of Parkinson's disease, my neuropathy patients fall. And when you superimpose that on top of a condition that already has walking imbalance as a problem, then yes, it is going to be an issue. And the way I describe it to my neuropathy patients is, you have three systems to keep you upright. There's your balance centers, which is your cerebellum, the back part of your brain, and your inner ear. There's your vision, your ability to see the ground, your feet, the floor, the horizon. And then there's your feeling of your feet on the floor. And as long as two of these systems are working, generally you're okay. But it turns out one system is not enough to keep you upright. So it turns out your brain and your balance centers cannot actually distinguish the difference between this movement and this movement. Those both register as exactly the same in your balance centers for a variety of reasons. And so if you only had that system working, your brain would not be able to tell what happened in your movement and where you are in space. That's why it relies on your vision and your sensations. So again, if we take away your feeling of your feet on the floor with neuropathy, that's going to take away one of your systems. Even if it's not complete, even if you can still feel some, it's definitely going to disrupt that system. And then you're really going to rely heavily on your vision. And so what I tell my neuropathy patients is you have to be extremely careful when you're in the shower because most people close their eyes to wash their hair or face. You got to be holding on. And in the middle of the night, when you get up to go to the bathroom, you have to make sure you have night lights everywhere because anything that disrupts your vision is going to throw off your balance. Now take that problem and throw it on top of somebody who shuffles or already has walking imbalance problems, and you can imagine where that's only going to make it worse. And so, yes, this is why it is important to think about because it can affect walking imbalance. I don't have good fixes for neuropathy either. But at the end of the day, it's important to mention or note because balance is such a dangerous problem. If you're my patient, you've heard me far too many times say falling is not your friend. Falling is by far the number one thing that lands my patients in the hospital, and that is not where you want to be. And so, while we already have to think about walking imbalance in my patients to begin with, neuropathy only adds a layer of complexity and difficulty to it, and that's why it's important to think about. This is a long story, so I'll try to kind of hit the important part. So my husband had Parkinson's disease. They started him on carbidopa, levodopa, and ramped it up very slowly. Um, I understand from other patients that taking medicine with food will avoid possible stomach upset, but when I read things, it cautions not to take the medicine with food, which I'll touch on in a second. Tremors in his dominant hand. That's why we started the medicine. He sees his doctor again in 6 to 8 months. So at the end of the day, there's a lot to that. And I think they were just asking for reassurance that this was the right plan. And I would agree. So a couple of things here. Generally, carbidopa, levodopa is the best drug I have. It's not perfect. I know it has problems. It may not even be the right answer, but in today's current literature, it is the best drug that I have to treat symptoms. And so, almost unanimously across the board, if somebody comes to my office, that's the first drug they're going to get put on. It's the one that tends to work the best. People feel that work the best, and it's the most effective in terms of quality of life improvement. But it does have issues. It has side effects. Biggest side effect is upset stomach, and that's where the take it with food part comes in. A lot of patients do notice, especially when they first start taking it, it makes them sick to their stomach. It makes them a bit nauseous. If you eat something or have some food in your stomach, it tends to help mitigate that nausea. Now, the other part of that is also accurate, which is food, particularly protein, tends to interfere with the absorption of levodopa. And so the pills may not be as effective. And I say may not because we don't really know. And at the end of the day, it's because everybody has this carrier protein in their stomach that carries both levodopa as well as large amino acids or protein across the blood-brain barrier into the bloodstream and absorb it. And depending on how much of that carrier protein you have, it may not make a difference if you eat food with your pills, or it may make a huge difference. I have plenty of patients that take their pills with food and they work just fine. I have equally as many patients who take their pills and even think about looking at food and they don't work at all. And so you really won't know unless you try it to see how food affects the absorption of your pills. That being said, generally I do suggest starting it with food, and then if you tolerate it, move it to an empty stomach, half hour before you eat, hour after you eat, something like that. Unfortunately, kind of one of the things that I'd like to highlight is it takes forever to get back into our office. So seeing your doctor again in about 6 to 8 months is probably not atypical. I hate to even mention what my wait time is. I don't even know what it is, but it's ridiculous. There just aren't enough of us, and that's what makes wait times so long. You will see us use our APPs a lot, our nurse practitioners, our physician's assistants to try to bridge that gap, but that's one of the probably biggest problems we have. But otherwise, I think that strategy is reasonable. It sounds like the symptoms are impacting his day-to-day life or quality of life. That's really the trigger that I use to want to put somebody on medicine. Now, I would also highlight the importance of exercise, and we would have had that conversation. But from a medication standpoint, that's probably exactly what we would normally do. Is there any pattern to how rigidity progresses throughout the body? Yes, there are patterns, but these aren't written in stone. Much like there's patterns with tremors. Generally, and I'm going to just say generally, I would say your average patient starts with a tremor and stiffness on one side, usually a hand. According to statistics, usually it goes to that same side leg before it goes to the other side arm, and then down to the other side leg, and somewhere along the lines, trunk, neck, head, they can all be involved. that's just the typical pattern. That is not written in stone. Not everybody follows that pattern. There is so much variety in how things present, progress, show up, change that I really even hesitate to say it out loud. That's just what's written. But just because you don't follow that pattern, or you do, or maybe something, doesn't mean that we're dealing with something else. There's a lot of variability to this pattern. That's just the classic. The next was a link to a trial, or a publication, which I thought was interesting. So, scientists may have found the true source of Parkinson's disease. And basically, it's about a new, I'm going to say new in quotation marks for a reason, brain network. And they called it SCAN. So they called it Somatocognitive Action Network. And I throw it in quotation marks because the more as I was looking through this and reading it, it sounds fascinating, but it's all the areas that we already know. So it's the basal ganglia, which is the deeper structures in your brain. It's all the same targets that we use for deep brain stimulator. It's the subthalamic nucleus, it's the globus pallidus, it's the putamen, it's the thalamus. And then it's some of the supplementary motor systems. And so these are all parts of the brain that we know are involved in Parkinson's disease. So I don't really think this is a new brain network. But what they were doing, I think, is actually interesting. Instead of the classic way that we learned neurology a long time ago when I was in training, where you have these nuclei deep in the brain, and they each have a specific function. And if you put a wire into those nuclei, or you put a hole into those nuclei, you know what's going to happen. They're kind of taking them as a whole. They're taking it more as a network. And I think this is actually a very forward thinking idea. So more and more we are learning that, we're learning this in stroke, we're learning this in multiple sclerosis, we're learning this in neuromuscular disease, that it's not discrete locations in the brain that are usually the culprit. It's how they're all interconnected, and it's that connection and pathways that are actually playing the role or dictating what you have. And so while I don't think this is really that new, I do think it's interesting in how they're looking at it as a network. And then more importantly, what they're doing is transcranial stimulation, which has also been looked at already with mixed results. And so they're looking at transcranial magnetic stimulation in people with Parkinson's disease into these certain areas in this network and seeing how they impact physical symptoms. And they're having some success. We have had some success using TMS in the past. TMS, just for your information, transcranial magnetic stimulation, is approved for anxiety and depression. And so it's used in the psychiatry world more than the neurology world. But there's a blend between these two specialties, and you're going to see us use more and more of this. I do have a guy here who's interested in it, and I've sent a couple of patients to him for this idea. I can't say we've had tremendous success yet, but I think this is something you're going to hear more of. I don't think we're there yet. I don't think this is really all that new, in all honesty, or all that novel, but I do think it's an interesting new way of looking at things, and I'm eager to see what they can come up with this stimulation. Because the benefit to transcranial magnetic stimulation is it's transcranial, not intracranial, meaning you don't have to drill a hole into your skull and put a wire into your brain, which I'm not against doing. But if there is a better or easier or less invasive way to do it, I'm also all for that. Again, I don't think this will necessarily take the place of DBS. That's always going to be something we have. But again, anytime there's new ideas out there, new ways to try to target these symptoms, I'm all for it. Have I found any medications that help my patients with cognition or memory? My husband has been having a lot of difficulty with performing simple tasks like opening cereal boxes, sealed containers, has been having trouble in dialing numbers on the phone. Does Lewy body dementia act like this, and is it treated any differently? So there's a lot of questions there. I have not had tremendous success with the memory medicines. So generally, when it comes to cognition and memory, we have the Alzheimer's disease drugs. We have the Aricept, the Namenda, the Exelon patch, which I like or prefer. Then there's galantamine. There are a handful of drugs. And these were all drugs that were approved for Alzheimer's disease, not memory problems in Parkinson's disease, not Lewy body disease, not any other disease. And the hard part that I run into with all of these medicines is that none of them fix the problem. And none of them really have any evidence or benefit that they actually improve the problem. What they have evidence for is that they slow down the problem. And the hard part about this concept is I can do a study and I can give 500 people a drug and I can give 500 people a placebo, and then I can map out the trends. I can show it on a graph and I can say, look, the people who took Aricept did better longer than the people who took the placebo, right? And that's how they got approved. That's exactly what they did. And they do work. But the hard part is if I give you the drug, how do you know if it works? And so I would say 9 times out of 10, people come back to me and say they didn't do anything. And I say, well, I wasn't really sure you were going to notice a difference because we don't really have anything to compare it to in terms of, is it keeping you better? Is it slowing it down? There's no way to measure that in any individual person. And so that's my problem with these medicines. I still use them. I use them a ton. Exelon's probably my favorite because it comes in a patch. But I use Aricept, I use Namenda. I prescribe these medicines when people come to me for cognitive problems because they're still the best drugs that I have. Exercise is still my favorite answer. Um, Don, I can't remember if it was you, but speed of processing games also have some evidence. That's the Brain HQ, which I do tell people about now occasionally. But at the end of the day, our options are still very limited. And these are still the medicines that we have. Are they as good as any of us would like them to be? No. But are they still the best that I have to give you? Yes. And so I can't say that I've found great medicines that have helped cognition and memory, but those are the medicines that I have. The hard part about Lewy body dementia is it is a little bit different than Parkinson's disease. Lewy body dementia typically happens early in the course. It progresses quicker, has very prominent visual hallucinations, even more so than Parkinson's disease. So there are some things that are different or variable in Lewy body disease versus Parkinson's disease. But the answer to your ultimate question is what I do for my Lewy body disease patients is very, very, very similar to what I do for my Parkinson's disease patients. I still have the same handful of medicines. I still talk about exercise. I still use a lot of therapy. It's just that I typically run into more problems with my Lewy body patients because they have more problems and they progress quicker and everything's a little bit trickier. The ultimate ideas are still relatively the same. It's just that we don't have as much success. And so that's kind of the distinguishing feature. But I wish we had better solutions from a cognitive standpoint. I got two more questions, I think, in my email, which have taken up all the time, and then I'll hit up to the top of this box and we'll go from there. I'll try to be quick. Um, the one question was, why is it preferable to use spinal anesthesia if possible versus general anesthesia? And this has a really long answer, but I'm not going to give it to you because I don't really know the underlying kind of pathophysiology. All I know is that when I did a study, and I did this one personally, I didn't publish it, but I did it when I was a fellow long time ago. And it wasn't a perfect study. It has its biases by all means, but I basically went back and looked at Parkinson's disease patients who had spinal anesthesia for whatever they were doing and had general anesthesia for whatever they were doing, and the general anesthesia patients did worse. Now, that being said, general anesthesia is also used for bigger procedures, longer procedures. So that could also have played a role. I mean, in all honesty, this is why I didn't publish it. I didn't think the data was good enough. But I have seen in my clinic enough patients get general anesthesia and have problems afterwards. Your brain was not meant to be artificially put to sleep and woke up. It's just not good for the brain. And that's where I think spinal anesthesia or local anesthesia or nerve block might be more beneficial in terms of the impact on the underlying disease. Now, it might not have anything to do with the anesthesia. It could be the length of surgery or what they have to do or any host of other variables. But I personally do think there is something to the anesthesia problem. But again, if you need a new knee or if you need a new hip or you need back surgery or you need lung surgery or abdominal surgery, last I checked, they're not just going to give you a shot of whiskey and a stick to bite on. They're going to knock you out. And then we have to work around that. It is what it is. And so if there's a good reason to do a surgery and they need to use general anesthesia, then that's what has to be done. And we just have to see the end result. I've had plenty of patients get general anesthesia and they did just fine. It's just we also know that it does have the potential to cause problems. And so that's just something to keep in mind. But that's why I think spinal anesthesia or local anesthesia might be a little bit better because it doesn't directly put your brain to sleep, which I think is where the problem is. And then the last one that I got an email was what my opinion was on the Watchman device. So the Watchman device is an atrial occluder for people who have atrial fibrillation. So people who have atrial fibrillation, your heart doesn't beat correctly or fully, clots can build up in these top parts of your heart and they can break off and go to your brain and cause a stroke. That's why atrial fibrillation oftentimes leads to being on blood thinners like Eliquis or Xarelto. And since I have a lot of patients who fall, being on blood thinners is questionable, not a great plan. And so that was the question. With the fall risks in people with Parkinson's disease, is the Watchman device maybe a better choice? Because after the Watchman device, I think, I'm not a cardiologist, a lot of people are able to stop their anticoagulation and their blood thinners. So from my standpoint, and I don't know enough about these things to really tell you that who is the appropriate candidate for a Watchman device. But if there is a way that that might be a reasonable option and that allows you to not have to take your blood thinners, I'm kind of all for it because falling is such a risk. Again, if it's not a good plan and being on anticoagulation is a better solution, then that's what we will do, and that's what we have cardiologists for. They're the ones who really know the answers to these questions. But again, if it is a reasonable device and they're starting to use it more and it's having good efficacy, I'm all for it if it makes things easier on my patients. I've been experiencing cramping in my hands, mostly in the way of the old Spock reading. What can I do to lessen? And no, I was never a Star Trek fan. I was a Star Wars fan. What can I do to lessen the length of these lasting? Well, again, that would prompt a few more questions from me, which is there any pattern to it? Does it respond to medicines? Is it when your medicines wear off? Is it when your medicines are at a peak? Because you can actually get peak dose dystonia. You can get wearing off dystonia, which is what that hand clawing sounds like. If it's not responsive or not fluctuating with the medicines, is there something else going on? Do we need to do an EMG? Look at your neck. I mean, there's a lot of things that I would ask based on that question. If it's medicine responsive, then maybe we just need to adjust your dosing or the timing of your medicine. If it's a side effect of the medicine, then again, maybe we need to adjust the timing and the dosing of your medicine. There are also things you can do for dystonic posturing, like Botox injections or other options. And so I would answer that question with a whole bunch more questions, just letting you know that there are some solutions or some treatment options, but to figure out which one would be the best, we have to answer some of those questions. What's the best way to address neuropathy? Since we talked about neuropathy, yes, neuropathy is common in Parkinson's disease. And again, it's another thing that I'm not very good at fixing. Neuropathy is tough because it's complicated. So what is neuropathy? That's question number one. So neuropathy is the feeling that you get when your nerve endings, the nerve fibers that are going down to your hands and feet are injured, damaged, or destroyed. Everybody thinks about diabetes, right? Diabetes comes with neuropathy fairly frequently because the blood sugar that's floating around in their blood clogs up the tiny, tiny blood vessels that feed the tiny, tiny nerves, and that ultimately destroys those nerves, and then you work back, kind of getting bigger and bigger and bigger. But diabetes is not the only thing that causes neuropathy. There's about 100 different things that cause neuropathy. And so the first thing we do, even though it comes with Parkinson's disease, is we make sure we're not missing something else, something that's potentially fixable, like a B12 deficiency, or a protein problem, or some other thing like that. If not, then we're left treating symptomatically. And the hard part is we don't have good medicines for neuropathy. If it hurts, if it's burning, or there's electrical pain, or shooting pain, or stabbing pain, all right, I got medicines for that. That's what gabapentin is. That's what Lyrica is. That's what Cymbalta is. Amitriptyline, nortriptyline. I mean, we have neuromodulators for pain. What we don't have good medicines for is really that numbness, the tingling, the feeling like I'm walking on gravel, or the feeling of unbalance. We don't really have good medicines for those. Those symptoms tend to not respond as well to the neuromodulators, and that's what makes it so hard to treat. If you're interested, I have had a little bit of success using an over-the-counter supplement called alpha lipoic acid. I learned this from my neuromuscular colleagues. I have no idea what the data is on this. I simply picked this up from what my partners use, and then I started giving it to some of my patients. I believe it's 400 or 600 milligrams a day if you want, but alpha lipoic acid is something to think about. I've had plenty of patients take that and not have any success as well, so just FYI. But at the end of the day, neuropathy is one of those tough things. And it's important because A, it can be painful and it can keep you up at night. And again, that's something we can work on. But B, it can also affect balance. And so all the more reason to work on exercise, work on therapy, work on balance training, particularly when you have neuropathy, because that only doubles down on the balance problems. Thank you for explaining to me what bergamot was. All I know is Earl Grey tea is really good. I like that. Let me open this. But the question is The rise of high-resolution imaging and patient-specific biomarkers is changing how we understand and treat neurodegenerative disorders. Are you familiar with this? I would agree with half of that sentiment, which is it is changing the way we understand things. I don't think it's necessarily changed the way we treat things yet. Yet being the key word. I do think, and now with 7 Tesla MRIs, which are, I mean, I'm going to be able to see all these nuclei soon. Those are not readily available. Most MRIs are 3 Tesla or even 1.5, but 7 Tesla are now available in certain places. That's a higher strength magnet, which gives you a much more detailed picture. I think as we use more of these higher resolution imaging, as I think tractography is another thing. So this is where they can actually map out where the nerves in your brain go and connect and functional MRI. I think as you see more use of these higher resolution or increasingly technologically advanced imaging, we are going to learn a lot more and we're going to understand these things a little bit better, not just the discrete nuclei or centers in your brain, but how they connect to the bigger picture. Because we know it's not just one thing. It is a network and a whole big picture. And so while I think this is interesting, I don't think it's changed our treatment strategies yet. But again, I think it has the potential to. And I think these technology is not going anywhere. And you know, even though I'm as bad as probably most, I don't love new things. I'm not somebody who changes or is flexible all that often. I can't argue with the fact that technology is advancing and we have to keep up with it. You are only going to see artificial intelligence used more, whether we like it or not. You're going to. You're only going to see higher and more advanced imaging used more. Whether we like it or not, you're going to. You're only going to see technology advance, deep brain stimulation technology, newer stimulator technologies. I mean, technology is going to, wearable devices are going to advance, and how we measure patients and get more data from patients is going to advance. And so technology is definitely advancing, and these are all things that I think have the potential to really give us more information, better information, more real-time information, and potentially open avenues for better treatment strategies. We just have to do it correctly. And that's where I think these research trials are interesting. You know, I love seeing progression in these things and see how they're going to be used, because I do think this is the wave of the future for what we're going to be doing. I don't know if carbidopa levodopa will ever necessarily go away, but believe me, as soon as they come up with better things, disease modifying things, cures, preventions, you're going to see us use a whole lot of these. And I think it's going to change the way we manage patients as a whole. More to come. I'm just going to jump to the important part of this, which is I was just curious your opinion of the LSVT BIG program, if you have any feedback. Most are well participating in our boxing program for Parkinson's. So I like the big program. So going back to the Lee Silverman voice therapy, where they came up with the loud program, which is teaching people how to reset their brain and speak in a more loud voice, and the big program, which is maximizing big exercises, big movements to try to reprogram your brain to do bigger things. Because generally the problems in Parkinson's disease are everything becomes smaller and more compact. And so I like them. I don't like how intense they are. So they're both 4 days a week for 4 weeks, but I get the idea that you need that kind of work to really see the benefits, especially in a month. That's a pretty quick time. Um, but I do send people for the big programs when they're interested. We have plenty of people around that do them. And so I really do think they are helpful. I don't think they're end all be all. And I have plenty of patients who either can't get to therapy 4 days a week, or their copay is $70 a session and they just can't afford that. And so I do think other, maybe less intensive therapies are good, maybe not equally as good, but good. I love therapy. I send patients for therapy all the time. And so while I do think the big and the loud programs are good, I definitely don't think they're the end all be all. I like the boxing programs too. Again, I don't think there's anything necessarily magical or curative about the boxing programs. It's great exercise, which I love. But if you're somebody who doesn't like boxing, then maybe that's not the right class for you. Maybe you go find a class that is for you. I do like that the boxing programs and some of the therapies kind of act as a support group, because everybody else there kind of is dealing with the same things and people hold each other accountable, which I've heard. And so I do think there's pluses to it. But again, one isn't necessarily the best thing for everybody. And so from a patient standpoint, I would argue find what works for you. If you like boxing and you want to go to that, be my guest. It does a great job. If we need therapy and you can do intense therapy and we can get you to a big program, great idea. If that's not for you, or if we can't, or if there's barriers, that's okay. We can find other things that can also work. We just have to tailor it to the individual people. Would you prefer to take the medication with carbohydrates instead of protein? Yeah, especially to minimize nausea. If you absolutely have to take your pills with food because they make you sick to your stomach and you really can't tolerate it any other way, then you do try to just minimize protein. Now, the problem with that is protein is also really important. You can't not eat protein. We need you to build muscle. We need strength. We need protein for what it does in the body, which is good. So you can't just cut out protein. But if you can somehow schedule your pills around times when you're eating less protein, I think that would be more beneficial. All right. Only two more questions. Man, I burned through these quickly. Good thing we're running out of time. Besides exercise, which is my favorite topic, in case you haven't picked that up, especially if you're my patient, you better know that. Is there any activity and advice to prevent falls due to balance and not environmental issues like throw rugs or clutter? Well, A, make sure there's no environmental issues like throw rugs or clutter. B, yes and no. So exercise is the only proven thing. Mainly Tai Chi actually has probably the best evidence for balance. I think all exercise is probably our best treatment strategy for balance. Mainly physical therapy working specifically on balance, but exercise as a whole is my favorite topic and really the only thing I think that really has any evidence to support its use for balance. I do think some people notice the medicines help. Now, you will hear me talk poorly about the medicines in terms of balance. It is definitely not the forte of the medications, right? Carbidopa, levodopa has never been the balance medicine. Amantadine, which I use specifically for balance, Exelon, which I specifically use for balance, have not been all that beneficial or proven in studies to actually help with balance. But I have plenty of patients that notice their balance is better with medicine. So we can't ignore the fact that, yes, exercise is far and away the best treatment. But look at your medicines. Is there any correlation with loss of balance, falls in terms of medications? Can we adjust your medicines to see if they would help? The other thing we have to keep in mind is, again, not only neuropathy, which can also throw off balance, but balance problems or dizziness can be side effects of a whole bunch of medicines too. So another thing to look at, or advice would be look at all your medicines and make sure there's not another medicine, a blood pressure medicine or something else that is leading to balance problems. And then it really is, especially around the house, if you need a device, you got to use a device. I mean, people hate to hear it. They don't like me telling them, hey, you need to use a cane, you need to use a walker. But I'm going to give you a hint. It is much better to use a cane or a walker than it is to fall, break a hip, and end up in the hospital. 10 times out of 10. I have a lot of patients that also have kind of furniture strategically placed, chairs strategically placed in their house. And so sometimes you can do that in your environmental space. There are now physical therapists. My physical therapist, Ian, was just showing me this company that will come and do kind of like an evaluation of your house and your setup and see what could be adjusted based on your needs. I don't think that's free. I feel like it's some expense, but I can't remember what it is. But nowadays, there are home therapists and occupational therapists that can do safety evaluations. So maybe that's another strategy if there's problems in the home. At the end of the day, my favorite go-to and my best suggestion is exercise, 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 physical therapy, physical therapy, physical therapy. Use assistive devices if you need them. Do not be that guy who's afraid to use them and doesn't want to use them and then falls because they didn't use them. Use them. Those are probably my best suggestions. And then the last question that I'll answer before I'll pass it back to Casey is anything new on the dopamine? All right. You threw another question in there. Last two. Anything new on the dopamine pump? So yeah, I have had a little bit more experience using the pumps. So there's two new pumps that are available. One is a NAPCO. This is an apomorphine infusion. This is a subcutaneous infusion of apomorphine, which is a dopamine agonist. It's about 16 hours a day. And then there's Vyalev, which is the phospholivodopa infusion, which is a 24-hour day pump. I have had a little bit more experience using these things, and I have had some relative good success. Not everybody. I've had a few patients not like it, stop it, whatever, and have to discontinue it. But I've had several patients who are continuing it. We're working on the dosing. It does, especially the Vyalev pump, the levodopa pump does take away a lot of pills that they have to take. The hardest part about the pumps is getting them. It's about a 3 month period. It's a several month period on my staff working with insurance, working with the company to get these things. It is not easy. There's a ton of hoops that we have to jump through, but in the patients that I have been able to get them for, I've been pleasantly surprised. I've been, surprisingly optimistic. I do think these are going to be important treatment strategies in the future. I think you're going to see me using more pumps because I have yet to meet a patient who is excited about taking tons and tons of pills very, very frequently. Never. And so I do think in patients, these pumps are going to be useful, but we have to be able to get them easier. We have to, there are things that have to be taken. They're not for everybody. Again, this comes back to the very individualized treatment strategy. And so I'm still optimistic on the pumps. I've had some good success or good experiences with them so far. Some not so good, but some good, mostly good. And so I do think you're going to see us use these more and more. And then the last question I'm going to answer is chronic fatigue a result of med or PD? And the answer is yes. Much like everything else, the answer is yes. It's a combination of everything. Parkinson's disease makes you tired. And I've talked about this before. I will talk about it again. In my experience, it is not a physical tired as much as a mental tired or emotional tired. And I say that because people come in and they say, it's not like I just worked out and I'm tired. It's because, and this is my interpretation, I'm making this up, but I think it's pretty accurate. Everybody I've told it to has agreed in some extent. It is thinking about everything you have to do. It is thinking about each step. It is thinking about swinging your arms when you walk. It is thinking about talking in a loud voice. It is thinking about writing your name smoothly and legibly. It is thinking about all of these things that we're going to say, quote unquote, normal people, I won't include myself in that, don't have to think about. That is very exhausting. When you have to think about, okay, pick up my foot, put it here, move my arm, take this step. All right, 3 tries to get up out of the chair. When you have to put forth brain effort to do these tasks that should not require extra brain effort, it is exhausting. And I really do think that is the main tired and fatigue that I get in a lot of my patients. And fatigue is the number one complaint I get in my office. It's the number one thing that we talk about right after frustration, but it's the number one complaint that I get in my office because it happens so frequently. And I think it's a result of the disease. Now, that being said, the medicines also make you tired, hands down. Every single one of them makes you tired. I have yet to find a medicine that just doesn't make people tired or compound that fatigue. You're going to hate hearing me say this, but I'm going to say it because I feel like it needs to be said. The only thing that I have ever come across in my 11 years, I think I'm on 11 and a half years now, heading towards 12 years of doing this, that actually helps that fatigue is exercise, getting up and moving. And I say that because I have tried everything I can think of. I've tried more dopamine medicine. I've tried antidepressants. I've tried stimulants. I've tried you name it. I have tried it, with the exception of the light box. I have not given that as good of a try as I probably should. Exercise is the only thing that I've ever had success with. People come back and tell me regularly, I feel better when I exercise. I have more energy when I exercise. And I always tell my patients, they say, well, how am I supposed to exercise when I'm falling asleep all the time? I'm like, well, when are you falling asleep? Well, when I'm sitting there watching TV. And I say, well, no kidding. You're going to be much more likely to fall asleep or be tired or exhausted when you're sitting, when you're comfortable, when you're in your own house. Get up, get out of the house, move, and exercise, and you'll be much less likely to fall asleep because it does become a vicious cycle. Then you sleep during the day, your sleep isn't as good at night, and so on and so forth. And so that's a very long-winded answer to get to exercise, which is always my favorite topic. But the short answer to your question is it's a combination of all of the above. And it's the number one complaint that I get. And it's an extremely difficult symptom to treat with medicines. It is not one that I have a good medicine for. Not to say I won't try, I will. But at the end of the day, I am not all that successful. And the key to success is getting up, being active, and exercise. And with that, Casey, I will end and I will pass it. I somehow got through like 7 emails of questions
Yes,
and all of these only 5 minutes late.
that was impressive. I'm glad that you talk fast and you have a good brain. And
Sometimes it's a good day. Go
we have
ahead,
a
Casey.
great
Anything you got
audience.
from you?
We have a great audience. Nice seeing everyone. Save the date for our Living Well conference on April 18th. It's at Robert Morris University in Moon Township this year. Registration coming soon. Oh, and there's a webinar on Tuesday, actually by Dr. Cusick on a multidisciplinary approach to deep brain stimulation. So a little more of a well-rounded approach. So that's Tuesday at noon, and it will be recorded as well.
And I will give him a boost too, because he's one of our neurosurgeons here, and we do have a good team that works together. And he's a really good speaker, and he's very well trained. So you should definitely listen to him.
Yes. Oh, and he'll be at the Cranberry Support Group tomorrow for you Cranberry folks.
Right.
Okay. Thank you, everybody. Thank you, Dr. Licklider. Have a good evening.
Thank you.
Bye.